My name is Fergal Monsell. I'm an orthopaedic surgeon at the Children's Hospital in Bristol. We cover a reasonably big urban area, but we're a level 1 trauma centre, and we take trauma from pretty much the whole of the southwest of England. And so that's my credentials to talk to you about two topics in children's orthopaedic and trauma surgery. So what I think you'll hear is some information that I hope you'll be able to use wherever you end up in practice about femoral shaft fractures in children, and the same sort of information about supracondylar fractures. I had an hour to talk to you about paediatric trauma, and I think the conventional way of starting at the shoulder and blasting through the arm and then doing the same in the leg is probably not very effective for you. You'll be sprayed with information, but nothing really you can practically use. So I've focused on these two because they're very common, and wherever you end up, if you're involved in the management of children's injuries, you will have to be able to look after these when you're in independent practice. And we'll talk a bit about the mechanism, a bit about classification, but treatment options is what I want to give you some advice about. There's never one way to manage any of these, and there are some nuances which I want to try and go over for you. Complications, I think, is always good to focus on, but not for too long. And alternatives. If two front-running alternatives exist, I need to try and make a case for why I would do one rather than another. So the first part is about femoral fractures, and I call it a shifting baseline for reasons that will become obvious. Now, pediatric orthopedics is a spectrum, and from a professional perspective, some days when I go to work, I need to be this kind old duffer, Dr. Mop from Camberwick Green, and behave in one way. And on some days, I need to be substantially more forthright and aggressive, and this is Genghis Khan. Because sometimes you need to do nothing more substantial than use a plaster, or nothing. Just kind words and advice is sometimes appropriate. But in some cases, maximum surgical violence is encouraged because some fractures require an aggressive surgical approach, which you'd be very familiar with from your adult practice. Now, the shifting baseline means that what is appropriate for this individual may not be appropriate for this individual or for this. So the shifting baseline is childhood physiology. And you have to have some idea about how that changes to inform you about what treatments are appropriate or inappropriate for an individual age group. And so for femoral shaft fractures, the shifting baseline, in my view, is between 0 and 6 months, 6 months to 5 years, and 5 to 16. It's completely arbitrary. I've made that up because that's how I think about femoral fractures. This is a 7-month-old child with a mid-shaft oblique femoral fracture. And the reason I put that up is because it's a very important point to get over. If you remember nothing else from any of this, this is what I want you to remember. This is an absolute minefield because a femoral fracture in a non-walking child is very concerning and has got a high index for non-accidental injury. This is one of the best papers on likelihood of individual fractures being due to a deliberate or accidental mechanism. And in their paper, there's about a 40% chance of a femoral fracture in an under 1-year-old child being due to abuse. And so it's difficult to conceive a mechanism in a child that can't walk. And there is all the fell out of bed, changing nappy, etc. That's usually unrealistic, and you have to find a cogent explanation for a fracture in this age group before you move on. So the mechanism is important, and in non-ambulant children, it's very difficult to fracture your femur. So the treatment is basically you keep them comfortable and they will heal. They will heal in a very predictable, rapid way, and deformity, even in the early stages, will rarely, if ever, be a problem long term. So in terms of management, it's the diagnosis of the mechanism rather than the treatment of the fracture. And so for 0 to 6 months, the two main devices that are used are either a Pavlik harness or gallows traction. And if we look at a Pavlik harness, you'll probably be used to this from DDH practice. It's actually quite a good device for managing femoral fractures. And that's because the person who's wearing it can't say, that hurts like hell. The children will settle very quickly. And I had to be convinced when I started using these that this was just another form of child abuse, because I thought, how can it be comfortable? But if you watch children in Pavlik harnesses, shortly after application, they're feeding, they're comfortable and they're calm. So the advantage is it's a very simple method of treatment. It is also very cheap because the patient can return home almost immediately. It doesn't require sedation. It requires a skilled practitioner to put a Pavlik harness on without annoying the child or the parents. The disadvantage is it is uncomfortable. Just because they can't say it hurts doesn't mean it's not painful. It is a fracture. It will feel, it's just that they can't articulate it. And that is a relative disadvantage. So gallows traction, again, is used not uncommonly. And this basically is tying a child to the bed using gravity to manage the fracture whilst it becomes sticky in the early stages. And then you can do something else, usually a plaster cast. There's nothing in any part of orthopedics that people can't decorate with science. But in this particular example, it's basically as you raise the legs, the perfusion pressure is altered. And if you have a heavy child with their feet in that position, there is a risk of distal ischemia. So you have to be thoughtful when using it. And so my guidelines are about 10 to 15K, provided with that, I can get one of my hand under the buttocks. That's enough weight. And so it's a very, very non-scientific way of doing it. I tend not to use it because we either use a Pavlik harness or immediate spiker. But for the very small kids, it's a very useful way out. Some people use a gallows for a period of time to, in inverted commas, allow the fracture to get sticky before putting it in a cast. And that's another point for discussion. So the 6 months to 3-ish years is a hip spiker. But I don't think it's suitable for very axially unstable fractures. So if you've got a high energy comminuted fracture, it's probably not the right thing to do. But particularly, and this is from my colleague, Mr. James Hunter in Nottingham, he doesn't use spikers in children who can answer back. And I think that's really him just saying that there is an age consideration. Up to 3 years old or thereabouts, I think is a perfect indication. Some people go up to 5 years, which I don't have any particular difficulty with. And the advantages of that is the short hospital stay. Our mean stay in hospital for a femoral fracture in this age group is 1.5 days. And they come in, they go on the next available trauma list, and they go home that day. And it can be a day case procedure if the family are, it's written down in the AO surgery reference. And there are step-by-step descriptions of exactly how to put a spiker on for trauma. And if you're used to the adult surgery reference, there is a pediatric component which you may not be aware of, but I recommend you look. The risks are pressure sores. If you do not pay attention to detail and you throw this on without proper padding, as with any cast, pressure sores will be a potential problem. And compartment syndrome is often talked about. I've never personally seen it, but it was written up nearly 20 years ago in the North American literature that on day case application of hip spikers were associated with a small series of compartment syndrome, but with devastating consequences. This is a typical picture of a boy in a spike. He's got quite a good use out of that. I've seen children ride bicycles with a one-legged spiker. They use their unplastered leg to do the pedal, and they just balance. They just get up to all sorts of things, and they'll just get on with it. It takes the parents about 3 or 4 weeks before they get used to it, and then it's time for it to come off. But it's a very effective way of looking after these children. In the 5 to 15 group, the options really are flexible nails. 5, anything below 5 is a little bit small. Anything above 12, you're probably missing the point, and we now have better inventory. You can plate any femoral fracture. There are some relative indications and contraindications, which I'll come to. And conventional nails, piriformis entry nails, I think you should probably not be using in paediatric practice for reasons I will try and convince you of. And so again, this is a technique which you should be all able to independently conduct before you start consultant practice. It is relatively straightforward, but there are points of detail that if you understand them, it will be much more straightforward. It is a very easy procedure to do badly. Nail size, rules of thumb, the diameter divided by 2 minus 1 millimeter. You're going to want to get a 75 to 80% feel of your narrowest part of the canal. And so you can basically work it out. But as you get bigger nails, they get much stiffer and they're hard to pass. And so it becomes a bit of a compromise. There are a number of sizes. The advantages of a big nail is its stiffness, and the disadvantages of a big nail is its stiffness. So it will be stable but hard to insert. And so there is a compromise. And also you have to contour these nails so the apex of the convexity of the bend in the nail is at the level of the fracture. And that will be a pair of equally sized, symmetrically contoured nails that when placed within the bone, that maximum contour is at the level of the fracture. That's quite hard to do and takes some practice. If you don't do it, you can get away with it, but sometimes you'll introduce deformity if you either incorrectly contour your nails, but particularly if you use nails of different sizes. You will almost guarantee introducing deformity if you don't obey that one rule. So if you forget anything else, the nails have to be the same size. I've seen people try and do this through a stab incision. Well, they clearly don't understand that someone's got to take these out. So my instructions are you put the nail in through a taking it out incision. But by doing that, it allows you proper visualization of where you're putting it. And so I want the nail to enter approximately 2 to 3 centimeters in a distal entry nail proximal to the physis. So I want a gap there because I do not want any physeal damage either during introduction or a pressure effect of the nail laying on the pericondylar ring at the point of insertion. So I want a decent skin incision. So 2 centimeters will allow you to get retractors in, and you can retract muscle out of the way until you see periosteum. And then when you can see that, it becomes much more straightforward. I've seen people sticking awls and drills blindly in and then wondering why, first of all, they skid off the bone, and second of all, why they can't find their holes. I hate this instrument. I've got this theory that if it's going to slip, it will always slip in the direction of the structures you want to protect. So in the femur, if it slips, it will slip posteriorly. And in one move, you'll have taken out the popliteal artery and a bunch of nerves as well. So I don't use this. I use a drill. I use a drill that's 0.5 millimeters greater than the diameter of the nail. And then I expand it as I put it in. I put it in with the shallowest angle possible to give me the best chance of passing the nail past the far cortex. You then got to cross the fracture side. Tips of the trade, really, if you put both nails in first, that allows you to control one section. You can put traction, you can change the orientation of the distal segment, and there are tools that come in the nailing kit that allow you to manipulate the fracture in the AP and the lateral plane. If you think about what you're trying to achieve, which is to thread a steel rod through 2 parts of a hollow bone, how hard can that be? Well, it actually can be quite difficult sometimes. So you need to set in your own mind a time limit after which you will not attempt any further closed reduction. And it depends on how I'm feeling, but it's about certainly no longer than 10 minutes. If I can't get a nail across the fracture within 10 minutes, it requires a small open approach so you can do a direct reduction. I see that as an understanding of technique rather than a failure of technique. I do get slightly anxious when I find that someone's been trying to do a closed nailing for an hour and 3/4 and they still haven't got any further. That's a misunderstanding. Complications, any operation has a risk of infection. Nail migration, particularly if you put a distal nail in, it migrates distally. You can get skin irritation and skin perforation. You can get knee stiffness because they do irritate the hamstrings and the quads. Non-union and malunion are rare, and they're usually when they're incorrect sizing of nails or incorrect patient. The conventional weight limit is 50 kilograms. Anything more than that, you probably ought to have a different device. And if it's a 50 kilogram younger child, plating is a good option. If it's a 50 kilogram older child, then some form of lateral entry nail. So plating, you all know how to plate a bone. So if you are stuck and you have no other way of fixing a fracture that needs fixing, you'll be able to plate one of these things. It's gone out of fashion, but it is an excellent treatment. Before the introduction of flexible nails, and when I was training 150 years ago, all femoral fractures over the age of about 5 were plated. It gives you a consistently good reduction, alignment, etc. It's very good in a multiply injured patient because you do not want to be doing your first flexible nailing in a patient that's in extremis. And if you've got someone who's very, very high tone after a significant head injury, you may find that you lose position with your nails or they're uncomfortable because of the muscle tone. And it's quite a good indication for plating. I think if submuscular plating and good pediatric inventory was available 25 years ago, that probably would be as popular as flexible nailing. That is a personal perspective, and people shout at me sometimes when I say that. The inevitable downside, it's a scar. It's a big scar. There's a lot of muscle stripping. There is probably an increased risk of infection. And then you have to retrieve the plate and there is a risk of subsequent refracture. But that is a list of complications that's common to pretty much any trauma procedure. A better way of plating it is submuscular plating for a distal femur. The anatomy is clear. You just go under subvastus approach. The plates are paediatric femoral shape, and it is a relatively straightforward procedure to undertake if you're used to using locking plates. And so that's one procedure I think you should be on top of for paediatric practice. In the older child, femoral shaft fractures are a worry because the fracture pattern almost demands an intramedullary nail. If you look at the vascular anatomy of the proximal femur in a prepubertal child, sole blood supply of the femoral head is as shown. And so if you want to think about where you're putting a piriformis entry, which is about there, and by the time you've reamed it, you've probably taken out the vast majority of the blood supply to the femoral head. And that is a worry because avascular necrosis in an adolescent hip is a life-changing complication. And there are case reports of AVN following femoral fractures, which led us to go away from that. We just did not want to use the nails that were present at the time. The best study, although it was a postal study asking, have you ever seen this, what do you reckon, looked at 1,600 fractures and found about a 1% risk of AVN using conventional entry nails. So that led to lateral entry nails, which is now pretty much mainstream practice for adolescent femoral fractures. And the tools that we've got, irrespective of who provides them, will allow you to most of the length of the diaphysis with recon options for femoral neck fractures. And that's another technique that I think is a very good one to master. I think I need to give you alternatives because there are a few fractures that demand an operation, and a closed, uncomplicated femoral fracture is not one of them. It's just the economic imperatives of keeping someone in hospital are huge. And if you are suggesting to someone that they have to remain in hospital for 6 weeks or more, whilst your parents have to work, children have to go to school, it's just not something that most people could, in their wildest dreams, accommodate. But occasionally it's happened. This is a patient who, for a variety of complex reasons, their parents absolutely refused any surgery at all. And even to the point of not allowing me to put a traction pin in the bone, that was off limit. I wasn't particularly comfortable about it. I thought this is going to end in tears, but we managed her on skin traction for about 12 weeks. And you know what's going to happen because otherwise I wouldn't show it. And she was absolutely fine. And so it just labours the point that you don't have to operate on anything. The options that I've given you for each individual age group, I hope, are sensible, reasonably clear. And I think that because this is something that you will be required to manage on day one of your consultant practice, it's something you should have a plan for. Everything I've just said to you is written down in that article. It's the European Journal of Orthopaedic Traumatology, most recent issue. It's basically pretty much all the stuff that I've just said to you. Part 2 is about the paediatric supracondylar fracture, because I know that this makes people very anxious. They go into it thinking it's difficult, and then it becomes a self-fulfilling prophecy in that it becomes difficult. And what I want to try and do is to demystify some of the aspects of this fracture to allow you to go into it in a much more constructive way and to not be afraid of it. And then what I think you'll hear is how they happen, why we classify them, again, the treatment options, complications and alternatives. It's a common injury. If you fall on an extended elbow, put body weight through it, particularly if you've got a tendency to hyperextend, is the bone will fail at its weakest point, which is at the level of the olecranon fossa. And the anterior cortex will fail under tension, fracture will propagate, then the posterior cortex will fail, and then it will displace. And it's a very consistent mechanism of injury. Much less common is a direct blow onto the flexed forearm, and that will cause failure of the bone at the same place, but the direction of displacement is reversed, and that becomes a flexion supracondylar fracture. The textbooks say about 5% are flexion, 95% extension type. Who gets them? And this is 2018, nearly 65,000 cases over a 5-year period, 50-50 male to female. Closed injuries, the mean is 5 years old with about 3 years spread either side. And that's certainly what I see in clinical practice. There's the Gartland paper for you. And what Gartland actually said in 1959 was that there are 3 types, those with no displacement, with moderate displacement, and with severe displacement. That's what the paper said. Over time, it's been translated into a grade 1, which is undisplaced, grade 2, which is displaced with an intact cortex, and grade 3, which is completely displaced. But what you really use is the modification. The key thing that we are trying to identify in classifying the supracondylar fracture is whether or not there is any bony continuity. And the point of that is, if there is translation, the fracture is complete and therefore unstable. This is the AO algorithm. The most important thing is, are there any signs of translation? Is there bony continuity? It's stable or incomplete. And that is a type 1 Wilkins type 2A. They are stable. If there is a loss of bony continuity, they are unstable. And they're the 2Bs and the 3s. The only way I classify these fractures are stable or unstable. And so when you're looking at a radiograph in your trauma meeting, for me, the most important radiological sign is that. That is translated. The only way that can happen is that there is no physical continuity between those two bone pieces, and therefore it's unstable. About 10% will have a nerve injury. I want you to examine this child at least 3 times. The first one is when you present, when you see them in the emergency room, you document motor and sensory function of all peripheral nerves. The most important time to do it is immediately before the child goes to sleep, because what you need to know when you're reducing it is exactly what the neurological status of that hand was before you do something. And if they're waiting around for 12 hours or more, that may have changed. So relying on the initial clerking, the initial examination, in my view, isn't enough. And you need to have up-to-date information of the neurological function. And the next most important one is when they are awake enough to tell you that they can still do everything. And you need to have those 3 time points of information. The only way to be absolutely sure of the most important one, which is the immediate pre-op, is the operating surgeon takes responsibility for examining that limb before they do an operation. And I put it to you that you'll save yourself an awful lot of heartache when you wake up, when a child wakes up and there's a nerve injury and you look and no one has written down the neurological status immediately before you start. That creates unnecessary difficulties. The only way of being certain it's been done is if you do it yourself. And I always do it myself. What can wait? Pink perfused hands can wait, but we all use surrogate signs for perfusion. And for me, the most important sign is the lack of muscle ischemia. So just as you would for a compartment syndrome, what I rely on mostly is passive finger flexion extension. If that's painless, then I know that that muscle bed is not ischemic. Now, it's quite hard to do that in a frightened child with a supracondylar fracture, but once they've been splintered in a back slab and they're distractible, you can very gently just play with their fingers to see that there is no muscle ischemia. What can't wait is an ischemic hand. And for me, we get muddled up because we lump together the skeletal, the neurological, and the vascular injuries all at once. So what I'd like you to do is to separate them in your mind into what do we need to do for the skeleton? What do we need to do for the artery? What do we need to do for the nerve? And for me, the only thing that can't wait is an ischemic limb. You may be at some stage in the situation where there is no one that can help you. Now, it's actually a very straightforward dissection, but you have to be aware of that the first structure that you will encounter when you open skin is these structures you're trying to protect. So the median nerve or the brachial artery will be pushed into the operative field. So you've got to be incredibly cautious when you make your original incision. And for me, I do a transverse incision in the cubital crease, and then I'll extend it proximally if I can't find the neurovascular bundle, and then distally to decompress it, and if I need to do a fasciotomy. And when you do that, actually the dissection's done for you. Your landmark is the biceps tendon, but it actually looks like a horror show. There's a big load of clot, a bone end, but you've got to identify the nerve and the vessel, protect that. It is unusual for there to be a direct injury. Usually it's external compression, either by bone or blood clot. And once you remove that, perfusion returns. It is unusual to have an intimal tear, and in a closed fracture, I haven't yet seen a transected brachial artery, but I'm sure they do exist. So again, I need to say that with a note of caution. I'm not being cavalier. This is a real life piece of advice. There are occasions where you have to just open up. And when you do it, it's a relatively straightforward dissection. The vessels are visible, they're in plane, but you've just got to make sure you protect them. The type 1 fractures, collar and cuff. So plaster splint, or simply just taping the arm in a flexed position. Plaster tends to be more comfortable. For about 3 weeks, again, it's a made-up number. They will become comfortable. They don't need any more than that, and they will be stiff for weeks afterwards, and the parents need to be aware of that. So if there's less than 15 degrees of extension deformity, the same as a Gartland 1, you treat them as an undisplaced fracture. And if there's more than 15 degrees of extension deformity, a closed reduction, and then a plaster cast. These are stable fractures because the posterior cortex and periosteum are undamaged, and they will tend to be intrinsically stable. So where you put them, you can expect them to stay. Again, 3 weeks is a magic number, but for the age group that we're talking about, the sort of the 5 to 8 year olds, 3 weeks for a metaphyseal or a metaphyseal fracture of the distal humerus is enough for comfortable healing. And the 2 Bs and the 3s require closed reduction and KY fixation. And so that is the prototype Gartland 3 fracture. So when we've got that sort of fracture, how do we do it? This is what I do. So you need basic kit, just a wire driver, a scalpel, just basic operative kit. And so the theatre setup is important as well. I want a lot of room. I want the intensifier where I can see it. And I do the initial reduction on the unprepped arm. It's personal preference. I just think you've got more arm if you do that. So the first thing you do is traction. And you need to put traction on for long enough to disimpact the distal from the proximal. If you don't do that, anything you subsequently try will fail. And that's why they don't work. People rush these things. Now, 5 minutes is a time that's thrown around. I sometimes have to go much longer than that, but it takes as long as it takes. And this is where you've got to be confident of yourself, because people will be looking at you. If you've been pulling on this arm and nothing's happening for 10 minutes, and people are looking at you sort of going, well, what's going to happen next? You've got to be confident that this is the right thing to do. Because what you're trying to do is you're trying to disimpact. And unless you can see a gap between the proximal and the distal segments, any other reduction will fail. So the next thing I want to do is I want to correct displacement. And so if it's medially displaced on the intensifier, push it the other way until that displacement is got rid of. But you've probably not completely reduced it there. If you see that, it's not anatomically reduced. And if you have that situation and you try and get rid of the extension deformity, it will displace again. You have to have it anatomically realigned. And so the next thing is there is a rotational component in that humerus that you need to take care of. And for that, what I do is I flex the arm to about 20 degrees and I pronate and supinate, and I watch on the intensifier until the medial and the lateral supracondylar ridge are lined up. And so when I can see that on the intensifier, I'm now ready to correct the extension deformity. And you put your hand over the back of the distal humerus. Now, the position of the forearm, in the books, it says you have to pronate them or sometimes supinate them. For me, you work out individually what the position that's required by seeing the forearm rotational position that reconstructs the supracondylar lines. And that is what you hold when you reduce it. That closes that gap. It is now anatomically reduced. So as I tape the arm up, because if it's not stable enough for me to walk to the prep room, then it's going to be a problem. So in that position, the majority are stable. And then it becomes just an exercise in putting 2K wires in an anatomically reduced bone. So first thing I do is I get the medial aspect of the humerus line drawn on it. That gives me a target to aim my wires. It takes out one of the axis that you've got to think about when you're putting your wires in. In a small, dumpy arm, it's easy to lose the position of the humerus. And I want to put my wires in. I aim for that line. I divide it into 3. I try and get the first wire, second wire, as divergent as possible, at least dividing into thirds. I use a leave-in dressing. You need something just to protect the skin. I cut the wires off and I put them in a back slab. And that is how I do a supracondylar fracture. And if you haven't got a better way of doing it, try that and see how you get on. And so it should be a day case procedure. They should be able to go on the same day, provided they are comfortable and have no neurological or vascular issues. And for me, the only thing I want to see is a normal neurological exam and the ability to actively extend their fingers. At a week, change them to a cast, 3 weeks. I don't think they need another x-ray. If you're going to x-ray them, my advice to you is when you're in the operator, you fix it, you're happy with the position. What you have to do is you have to look at the position of the arm in extension and compare it with the other side. If it is visually identical, then that fracture is reduced sufficiently. Even if the radiological appearance is not absolutely anatomical, the functional position is fine. The next thing you should do, look for the worst x-ray and save that. Because if you're prepared to leave the operating room with that picture, when someone else x-rays it and it's in a different rotational position, then they'll know it hasn't slipped. I see them at 8 weeks just to make sure that they are neurologically intact, they've got a good range of movement and alignment. So not every supracondylar fracture is identical, and these are all supracondylar fractures, but they have all got fundamentally different spin that needs to be anticipated. The obliquity of that fracture, it goes from low lateral to high medial. And the problem with that is if you try and put a lateral wire into that, you're pushing it into a displaced position. It's intrinsically unstable and will slide in the direction that your wire wants to pass. And so you will struggle to keep that reduced while you put your wire in. That, for me, is a good indication for a medial wire. And so a medial wire, you have to know where the ulnar nerve is. You have to protect it. There are books written about how to do that. I don't care how you do it, provided you don't damage it. This is a T-shaped fracture. It's high. It's metadiaphyseal, and it's very difficult to control that with K-wires. And on some occasions, you have to use the same tricks as you'd use in a 20-year-old distal humeral intra-articular fracture for paediatric fractures. There's the flexion supracondylar fracture, which I told you about, approximately 5% R, but if you do the reduction maneuver I've just described to you, you will make that substantially worse. And the patient will wake up with a considerable loss of extension, which will be fixed. That is much more disabling than the varus valgus malalignment that you get in the extension fractures. I tend to fix these with the arm extended. The best is the enemy of the good, which I think is very, very important for this fracture, because what I want you to avoid multiple attempts at reduction. If you're on the 10th attempt at reducing a fracture that is just all over the place, you've probably already destroyed the posterior stabilizers. That is going to be a really difficult fracture to manage. You need an alternative, which I'll give you in a minute. Multiple passes of the K-wire, that's an epiphysiodesis. So if you pass a 2mm wire, which is the recommended diameter for this fracture, 10 times into the distal humerus of a 6-year-old, you've damaged the growth potential of that. Why we don't see more growth arrests is something I can't explain, but it cannot be a good thing, and it is to be avoided. If the arm looks the same as the other side and it's stable through flexion and extension, then the position is fine. It does not require adjustment and fixation. And if you see it a week later, I think that's probably the worst time to try and revise, because the pins are a little bit contaminated, the fracture will be a bit sticky. I think it is not a good time to revise, and it is rarely necessary. And think about that trick about getting the worst x-ray, saving that rather than the best x-ray, because then you'll see that this is not a deterioration, it's just a different projection. And what is acceptable? There's been some work that has been going on in Toronto, and what they found is that you can get 30% of medial displacement, 15% lateral displacement, 30% posterior, 25% anterior displacement. Now, it just tells me that you can actually have quite a way off anatomical reduction and still be okay. But if you look at those, they are all translation. For the angulation, they measure the Bowman angle, which I find very difficult. I compare it to the Bowman angle of the uninjured side by doing a visual assessment at the end of the case. And so this is a case I want to show you. And if you look at that spike of bone, that has gone an awful long way. That has got to go an awful long way to reduce. And maybe I was having a bad day, maybe I'm not very good at these, but I could not reduce that. I retain the right to manage these fractures on traction, which has considerable implications for a family, but it is a potential alternative. And I probably do it every couple of years, and I always go into these with a consent for traction. If you do that preemptively, then it's no surprise to the family. So the salamander treatment, the salamander, as you know, if you pull their legs off or their arms off, they'll grow a new one. So how does that work in humans? Well, this is a patient whose x-ray I showed you. I couldn't reduce it, so I said, right, I get the smallest Thomas splint in the hospital, and I just put it on straight arm traction, and I look to make sure that it looks the same as the other side, and they stay in bed until it becomes comfortable for me to squeeze the fracture, which is usually about 4 or 5 days, and then I put it in an extension cast. And that's what it looked like, which is absolutely terrible. I showed this to people and they said, well, you're going to go to jail now. It's translated. It is barely angulated. If you follow it, it heals. She lost flexion because the radial head was abutting onto the previous metaphysis. But it does grow, and if you wait, it has to grow about 0.5 centimetre, and it will grow away from the fracture. But she ended up with normal alignment, normal function, and a story to tell. And it just shows you that traction in the right patient is an acceptable alternative, but there are better options, which I hope I've told you about as well. We also wrote about supracondylar fractures in the European Journal of Orthopaedic and Trauma Surgery. It's open access, so if you're interested, you can just download it.